Okay, hello everyone. We're going to go ahead and get started. I wanted to welcome everyone to our biannual virtual education event through Rocky Mountain Cancer Center. My name is Dr. Patrick Richard. I'm a board-certified radiation oncologist practicing in our Boulder clinic. I'll be the moderator for today's event, talking with three of my partners about an important topic in men's health, oncology, and hematology. We hope that this presentation will benefit you and your practice. I'd like to start off by introducing the panelists today. We have Dr. Dennis Carter, who's a radiation oncologist in our Aurora clinic, Dr. Greg Britt, who's a hematologist and medical oncologist in our Boulder clinic, and Dr. Tim Murphy, who's a hematologist and medical oncologist, as well as our practice president in our Colorado Springs clinic. So as usual, before we get started, I'd like to cover just a few housekeeping rules. All of our attendees are muted today to eliminate background noise and keep our panelists on topic. However, we'd love for this to be an interactive experience and would encourage you to enter any questions, comments, thoughts into our chat and Q&A function, and we'll make sure to direct those to the panelists during the presentation and likely after. For those of you who carry COPIC risk insurance, do want to remind you that this is tracked. The attendance will be recorded, and you will earn that coveted ERS point. And again, I want to thank you for taking time out of your busy day to join us today. We've worked with all the panelists to come up with some very important topics. We'll be covering cancer screening with Dr. Carter. I'll be talking a little bit about important topics in prostate cancer. Dr. Britt will be covering testicular cancer as well as the treatment effects on a man's sexuality into survivorship. And then Dr. Murphy will be talking about colorectal cancer. So our first topic is going to go to you, Dr. Carter. What in general are the recommended cancer screenings that we advocate for our male population?
Yes, thank you. I have shared screen here, and I'm going to be talking about for men, colon cancer, lung cancer, and prostate cancer screening guidelines. And this is taken from sources, a variety of sources such as the U.S. Prevention Services Task Force, the American Cancer Society, and various professional associations. But essentially for colon cancer, the main recommendation for ages 45 to 75 is regular cancer screenings. The main update here is that now the recommended starting date is 45 instead of 50. And in addition to that, before age 45, testing may be recommended for high-risk population. And after the age of 75 until 85, it's really to recommend discussing screening based on the patient preference, life expectancy, prior screening history, that sort of thing. So if someone has, some concerning findings in prior screening and a long life expectancy and desire to be aggressive, that's still quite reasonable. After the age of 85, it's favored that you discourage screening for colon cancer. Among the high-risk population, say under age 45 or more frequently after the age 45, includes a personal history of colorectal cancer or polyps, a strong family history of colorectal cancer or polyps, a history of ulcerative colitis or Crohn's disease, or a personal or family history of genetic predispositions such as Lynch syndrome and similar types of syndromes, or prior radiation to the abdomen or pelvis. And in terms of which exactly the tests, there's a wide range out there and not a lot of guidance in terms of which ones you should use, but here are some acceptable options. And so the first two are annual stool tests looking for evidence of blood in the stool. And then there's a more recent multi-targeted stool DNA test that can be done every 3 years instead of just annually for the blood-based stool test. All of these require a colonoscopy if positive, and there's various differences between them in terms of sensitivity and false positives and that sort of thing. But then the visual structural exams are the mainstays: colonoscopy every 10 years or virtual colonoscopy every 5 years. Flexible sigmoidoscopy has pretty decent data, although sort of this intuitive concern that we're only looking at part of the colon, and there's perhaps more variation in terms of how that might be conducted in the community. And for particularly the structural examinations, all of these tests are more frequent if patients are found to have certain risk factors or findings, such as some of these high risk factors, or found to have polyps and that sort of thing. So that's the basis of colon cancer screening. Again, the main change from prior is that we're starting at age 45 instead of age 50. And then after the age 75, to just have discussions and kind of decide between you and the patient what you want to do with that. So lung cancer screening, that has been around for several years now, and I'm sure people in this call are familiar with the basis of this, but essentially lung cancer screening with a low dose CT scan is now recommended and widely accepted for prior smokers who have at least a 20-pack-year history of smoking for patients between the ages of 50 and 80. And the main changes here over the last year or so has been that we're now starting at age 50 instead of age 55, and starting it with patients as little as 20-pack-year history of smoking. And just by making these changes, it approximately doubles the population that's eligible for CT-based lung cancer screening on an annual basis. The next category is prostate cancer. So the recommendations for this are essentially to discuss screening with PSA for patients ages 50 to 69 as a routine population, and then make that decision based on patient preference, family history, life expectancy, and that sort of thing. And then for before age 50, you can start as early as age 40 for screening high-risk populations. And so that the high-risk populations would be African Americans with a positive family history, men with first-degree relatives of prostate cancer younger than age 65, and known genetic predisposition to prostate cancer, such as the BRCA1 or 2 genetic predispositions to cancer. So that's the mainstay for cancer screening, and that are recommended from the large associations.
Excellent. No, it's a really nice, concise, data set to be aware of when figuring out whether we should be referring for screenings. I think really maybe the hot topic of the day will be, what are the controversies with PSA screening? If you can touch on some of those elements.
Sure. I'd like to approach this from an intuitive standpoint, and really, if you look at this last screen, the decision is based on patient preference, family history, and life expectancy. Well, what does that mean? It really comes down to that we all see patients with prostate cancer. It's a common cancer. People die from it. They have lots of morbidity, lots of bone pain, and we've all experienced that in our practices. Certainly we have, and I think in primary care, it's such a common disease that it's experienced there. And so what can we do about this? And PSA has long been advocated as a way to resolve that. The tricky part is that there's not a bunch of data. There's no real good survival data, even in terms of how the treatment is effective. We now have, for favorable risk, so Gleason scores of 6 or less predominantly, that the survival is not really impacted by treatment out to 10 or 15 years. And so, why are we even screening if we don't even have a treatment that has been proven to impact survival? Now, it does impact survival at the higher risk categories, and there is morbidity, impact for sure. And in those studies, and I think they may be discussed later in this setting, but in those settings, 75% of men still wind up getting treatment. So it's not necessarily do they get treatment or not get treatment, and does it impact survival, but it's really, are they getting treatment now or are they getting it later? And it does make a difference in some of that population in terms of certainly PSA control, bone mets, and morbidity, and that sort of thing. So there's this controversy about how much difference it makes, because and the fundamental nature of this is most prostate cancers we detect are an indolent disease that take many years, over a decade typically, before they cause significant morbidity or mortality.
Excellent. Yeah. And it's, comes up quite a bit. It's actually a nice segue into kind of the second topic that I'll be discussing, which is, prostate cancer a little bit more specifically. I think it's helpful to understand, the important elements that we consider when, discussing whether a referral should be made for an elevated PSA and what extent of the workup should we pursue. I think you've hit on some of the common elements that we discussed, Dr. Carter. We know that not every PSA is a prostate cancer or is a prostate cancer that could be relevant in that patient's life. So I think it's important that when a primary care provider is referring to a specialist to deal with this elevated PSA, that they basically have a balanced discussion with the patient. Sorry, my light just went off here. They basically have a balanced discussion with the patient in terms of what further workup should be, what is the implications of the elevated PSA. We have a lot of sophisticated tools now that we can actually use to help predict what the likelihood of that PSA being even related to a significant cancer is. And that's really kind of rounded out the decision making in terms of the workup of the PSA. So I would encourage our primary care colleagues to understand who they're referring to make that call, and really ensure that they're doing shared decision making with the patient to see what else needs to be done for that prostate cancer. The other thing is, we've seen a little bit of shift in the mantra that we used to apply for guys with prostate cancer, which is, you won't die of prostate cancer, you'll die with prostate cancer. And whereas, as Dr. Carter mentioned, that is the case for a lot of men with prostate cancer, that doesn't hold true so much for men with intermediate risk or high risk. And it doesn't hold true for a lot of patients that even when they're diagnosed with a low risk cancer, still are a bit uneasy about what the future holds with it. And they elect to do treatment to really make sure that the cancer is cured and not going to jeopardize their health or their function. So we have a lot of sophisticated tools now to understand the personalized risk that each prostate cancer plays for the patient. We're utilizing a lot of genomic testing where we can predict the risk of metastasis. We can predict the risk of mortality. We have more sophisticated imaging like PSMA PET scans where we can determine whether it's a localized cancer. And we utilize all those tools to, again, the end result is have a personalized risk that we apply to each patient, which leads nicely into that shared decision making. The other key element, in my opinion, to discuss when making a referral is the provider or the clinic you're referring to a part of true multidisciplinary GU care. We've seen a number of different settings develop in the Denver metro area in terms of a lot of urologic combination practices where they're geared towards one treatment or the other. You want a system that has unbiased recommendations and can actually sit down and review each case prospectively in a multidisciplinary setting. That's one thing that we pride ourselves on at Rocky Mountain Cancer Center, is being a part of those multidisciplinary tumor boards or cancer conferences. And this is an excellent opportunity to review each case, understand the data, the risk, and whether this cancer is actually something that needs to be treated, or we can follow them as a team if they choose active surveillance or choose active treatment. So I think that's all really important. Again, it's a complicated situation because a lot of prostate cancer doesn't need to be treated, but it's important to know the risk and how that could affect each patient. Switching gears a little bit is now that we do have a diagnosis, a lot of patients, whether it's low risk or something that's high risk, want to sit down with providers to understand those treatment options. As we all know, one of the biggest decisions that these guys are faced with is the local therapy decision. Should I do surgery? Should I do radiation? And there's not, one person that really has this decision very easy. About, over half of the guys that I meet with are struggling with this because with prostate cancer being a very common cancer, they know somebody that's had surgery. They know somebody that's had radiation. There's pros and cons to each. But I kind of like to pare it down into three main discussion points. The first is the process and logistics. As we know, surgery's made a lot of advances in terms of the robotic laparoscopic prostatectomy, which has cut down, hospitalization stays, the recovery. Being minimally invasive has been a real game changer for our urologic colleagues. The logistics are very different. Obviously, they have to be physically fit and able to tolerate that surgery and make a recovery. So ideally, we like recommending surgery for younger guys with good urologic health that can make that recovery. With radiation, we have a ton of different treatment options. The logistics are very different. We can deliver treatment in as few as 5 treatments versus sometimes 8 to 9 weeks, which is obviously a lot more cumbersome than a single outpatient surgery. And so I kind of, go over those process and logistics, and I just find that, some guys just gravitate towards, getting this thing out and removed. And a lot of guys, like the non-invasive nature of radiation. Obviously, we touch on the efficacy. We're not going to recommend any treatment for somebody that we don't feel is going to put them in the best possibility of cure. Generally speaking, for very low risk or low risk prostate cancer, local therapy with surgery and radiation is proven to be pretty much equivalent. I will say, as we march up that risk spectrum into intermediate risk, high risk, very high risk, generally speaking, we recommend multimodality treatment for those guys given the higher risk of metastasis. And it's more likely that there are some worrisome signs after surgery that would warrant the use of radiation or hormone therapy. And so we try to, again, meet with each patient, understand their wishes and concerns, and try to, guide them to a shared decision. And then lastly, side effects. We see quite a difference in side effects with the surgery versus radiation. Most guys that choose to undergo radiation are really a little bit afraid of some of the impact on their continence. So incontinence is one of the main side effects of a radical prostatectomy. Radiation causes more irritative symptoms that can be challenging for a lot of guys to recover from. We see a difference in some of the bowel side effects with radiation versus surgery, and then the rates of erectile dysfunction. So again, we try to hit on all those elements, and it's not uncommon that we're spending 1 or 2 hours with patients just really fine-tuning what their goals and desires are and making sure that they have all the information they need to guide that decision. So again, that was kind of a quick run through on some of the important aspects of prostate cancer. Feel free to leave comments and questions along the way, and we can come back to cover it. So I'd like to switch gears a little bit to you, Dr. Britt, with really some of the key concepts in the management of testicular cancer. Just wondering what the risk factors are that can increase one's potential for developing a testicular cancer. You're muted.
Thank you. Thanks, Patrick. Yeah, so, I think that, testicular cancer is less common than some of the cancers we discussed, but, it is, there's a rising incidence seen in the Caucasian population, for example. There's about 9,000 cases diagnosed annually here in the United States. Risk factors would be, classic kind of medical school teaching is undescended testicle, and that's why that's important to be managed appropriate in an infant. You also want to know if the patient's had testis cancer before. Doesn't happen often, but there's about a almost 2% chance of contralateral, recurrent testis cancer in the other testis if they've had it before. Family history seems to increase one's risk. There is a link with HIV and also some evidence that heavy marijuana use is also associated with increased risk. And the reasons to learn about these risk factors is because really there isn't a screening test for testis cancer that's would be reliable.
Yeah, no, excellent points there. And another question is, what is your approach to surveillance? So after a patient completes treatment, to evaluate for the potential for recurrence, what would be your approach to surveillance in that situation?
Yeah. There's some really nice guidelines put out by NCCN and other groups, but basically, some of it depends on what was done, what their stage was. Do they have a stage 1 and we're following them with active surveillance? They get an orchiectomy, but no additional treatment. Surveillance is going to be really important. There are some nuances between whether the patient had a seminoma or a non-seminoma, but essentially, we want to follow them pretty closely in the first year or two with history and exam, and then do the appropriate tumor markers and scans, chest X-ray or CT scan of the abdomen and pelvis. And I think this is really critical. Fortunately, survival rates with testis cancer are very high, but if you're missing recurrences, then obviously those are the patients that can do poorly. And I think most of our patients are very reliable, but there are some that aren't, and they move. These are young patients, so sometimes there's some invincibility, and so I think primary care can play a big role in making sure that patients are getting back to see an oncologist or urologist, or in some parts of the country, I suspect, or rural areas, primary care doctors can do a lot of the surveillance as well.
Excellent point. And as you mentioned, testicular cancer is a cancer of young men that could want to preserve their fertility in the future. So I'm just curious, what patients would you recommend sperm banking for before treatment?
Yeah, my recommendation is that all patients highly, I recommend sperm banking in all guys with testis cancer. If it's a stage 1 cancer and they're not going to need chemotherapy, well, it's just insurance against the catastrophic loss of the other testis. As I mentioned, almost 2% of patients with testis cancer can get it in the other testis. If they have a higher stage and they're going to need chemotherapy, then it becomes even more obvious the need for sperm banking and the decreased fertility that can come with chemotherapy.
Yeah, excellent. Thank you. And we'll circle back around with you in a little bit for the sexuality topic. But let's switch gears to you, Dr. Murphy. Seemingly diagnosing a lot of colorectal cancer in young patients, and some of those may have hereditary risk for that developing. So I'm just wondering what the implications are for somebody with Lynch syndrome or other hereditary risk in regards to colorectal cancer.
Sure. Thank you, Patrick. For my topic, given the audience of primary care providers, I chose to focus on a couple of items more in the survivorship, and that is how we should be following and managing survivors of colorectal cancer who might have Lynch syndrome, and the second is the overall long-term toxicities we have to be looking for. And when I say we, I really mean my primary care providers, because survivorship is becoming a huge topic in our country. We've got over 20 million cancer survivors now, so a lot of the follow-up care for cancer survivors is going to end up back at the primary care office. So part of what I'd like to get through today is how best to team with our primary care providers in following all these survivors. Now, in specific to Lynch syndrome gets a lot of press, and it's sort of, it when you see it, because when you take your history of your patient, you'll see that mom had endometrial cancer, brother had colon cancer, uncle had colon cancer, prostate cancer, gastric cancer, renal cancer. These are autosomal dominant germline mutations. So these are very apparent when you take a family history. But in reality, Lynch syndrome only accounts for about 5% of all colorectal cancer cases. But it's really important to identify those folks because of their significant risk of other cancers. And typically when you see this history, and if you get germline testing, and RMCC can help with these patients and these families, we can do the appropriate screening and follow these patients. There are very strict guidelines on how to follow Lynch syndrome families over time, because it's quite rigorous. They need virtually annual colon cancer screening starting in their mid-20s. The women with Lynch typically will require hysterectomy and oophorectomies and all the downstream complications from that. Once their child rearing years are over, they need screening for upper GI tract cancers, EGD screening, typically on an every, depending on which society you read, 3-year basis starting in their 30s, screening for gastric cancer. There's an increased incidence of pancreatic cancer and renal cell cancer. So these people have very vigorous needs in terms of follow-up guidelines. And these are well worked out. You can go to, I think Greg had mentioned the NCCN guidelines. These are well spelled out in nccn.org. Any provider can get access to that. It's a great resource for survivorship issues, particularly genetic predisposition, such as Lynch, but also our own guidelines, ASCO, American Society of Clinical Oncology, American Cancer Society, all have very rigorous guidelines to follow Lynch families. To the point, Patrick, where it's a bit unsettling. If I'm a primary care provider, I'd be a little bit nervous about the medical legal implications if you were to miss an EGD on a patient, just because there's so much rigorous screening mandated that it makes sense to get these people to a formal genetic counseling session, and certainly we can help follow those patients and their families and make sure they're hitting all those milestones for screening during their lifetime.
Excellent. Yeah, and specifically with colorectal cancer, many stages and forms of this can be cured, and we know that some of the treatment can have long-lasting effects. Yeah. What would be some of the big ones for our primary care colleagues to be on the lookout for? Yeah,
so again, 20 million cancer survivors, only predicted to grow to 25 million over the next 10 years. So colorectal cancer survivors make up about, depending on what you read, about 10% of all cancer survivors in this country are survivors of colorectal treatment. So again, we're going to really have to rely on our primary care doctors to recognize what they should be looking for. Not within the first 5 years of diagnosis, because that's usually when the oncologists are fully engaged. Maybe the patients finish their treatment, but we're following them very vigorously for about 5 years. But after 5 years, we'll kind of dismiss those patients back to their routine primary care. So we really want to make sure the PCPs out there know about those guidelines. And again, those references, nccn.org has a wonderful slide deck on survivorship. So specifically colorectal cancer, long-term complications really fall into 3 buckets: the surgical bucket, the chemotherapy bucket, and the radiation bucket. Surgical really depends on colon versus rectal surgery. Rectal surgery comes with a little bit more long-term complication rates. But a standard transverse hemicolectomy or right-sided hemicolectomy, not a whole lot of long-term surgical complications. There could be adhesions and some bowel obstruction. But for the most part, and then of course hernia, much less incidence of hernias, ventral hernias, now that they're doing most of these surgeries with the robot and laparoscopically. From the chemotherapy, which is kind of what I do, actually very few long-term complications from the chemotherapy. The one that stands out the most for colon and rectal cancer really has to do with one of the biggest breakthrough chemo drugs that we use. It's called oxaliplatin. Most of the folks on this call probably recall cisplatin during your medical school training and maybe even residency. Cisplatin is a very old and commonly used chemotherapeutic. Oxaliplatin is just sort of next generation platin drug, but it comes with some baggage. It's really improved overall survivals of colorectal cancer patients, but it comes with a pretty significant increase in peripheral neuropathy. And that's been a real bugaboo for us. We've tried lots of things over my career to minimize peripheral neuropathy, and nothing works. Infusions, we did amino acids, we did nutritional supplements, we did all sorts of stuff, and nothing mitigated these risks. So oxaliplatin comes with peripheral neuropathy. What I tell my patients is be patient. Peripheral neuropathy is only permanent in about 20% of colorectal cancer patients. And it's usually those people who might have underlying diabetic neuropathy to start with. So if they're diabetic and getting their colorectal cancer treatment, they have a high risk of having more permanent neuropathy. But most of the neuropathy is reversible. I tell people it's 2 years, it's 24 months before it can finally go away. So you just have to be patient. From other chemotherapy exposure, it's kind of the same. Chemo is chemo. It can cause anemias, bone marrow damage. So these people need to be screened annually with CBCs, make sure they're not going to develop anemias, leukopenias, thrombocytopenias. But by and large, it's peripheral neuropathy. That's the biggest long-term risk factor. There are higher rates of coronary disease in colon cancer, colorectal cancer survivors. Higher rates of diabetes in the adult years too. So it's really, it just comes down to good primary care. And then the final is the long-term radiation therapy, long-term risk. And that's where you get more into the, like what Greg said, and I think Patrick, you mentioned the sexual dysfunction issues. You get into bowel continence issues, urinary continence issues. Those are, if you, and again, you don't see that particularly in colon cancer because we typically don't incorporate radiation into the treatment plan for colon. It's really just rectal cancer. And when you add that radiation after that surgery and down in that deep pelvis, you just start seeing higher incidence of bowel continence. So these folks generally do need a long-term relationship with a gastroenterologist. Obviously, there's a small proportion of colorectal cancer survivors who have permanent ostomies, not as common as before, but that it still happens. So ostomy care, living life with an ostomy, the psychosocial issues that come with that, those are just long-term issues that have more been linked to the long-term radiation risk. But again, I stress the key here is typically after about a 5-year period, these folks are going back to their primary for their follow-up care. So we really want to make sure that A, the primary care base is educated as to what to look for, B, when to get us back involved, and C, obviously we're here to answer everybody's questions, and we're easy to get a hold of. We're up and down the Front Range. So any of us would be happy to help guide people through their survivorship.
Excellent. Thank you, Dr. Murphy. That was a nice comprehensive overview of the colorectal topic. Our last topic is going back to you, Dr. Britt. We know that, as many of us have alluded to in this topic, a lot of these treatments can affect a man's long-term sexuality and their function, and that's something that a lot of guys do prioritize and kind of rank high on that side effect list. With testicular cancer, primarily first starting off with an orchiectomy, we know that can lead to low levels of testosterone. What would be your recommendation to supplement that testosterone in the future?
Yeah, it's a great question. I mean, I think probably about 5 to 10% of young men who undergo an orchiectomy can develop symptoms of hypogonadism. Typically, I'll give it about a year to see if that just kind of improves on its own. We talk about, a better diet, exercise, but, if that's not working and it's really affecting their quality of life, causing fatigue, depression, decreased activity, weight gain, decreased libido, then I would certainly refer him to, either, an endocrinologist. Some of the urologists are doing it. Some medical oncologists will do it, but I would talk about testosterone supplementation. I do like to let young men know that testosterone supplementation can decrease sperm counts. And so again, there could be that risk for subfertility or infertility, in which case, back to kind of my earlier discussion, if they haven't undergone sperm banking already, I probably would have them do that just in case prior to starting T therapy.
Excellent. And along those same lines, a very common question we're getting in clinic, and I'm sure our PCP colleagues are hearing is, with prostate cancer being a hormone-sensitive cancer, analogous to what we see in breast with estrogen and hormone replacement therapy, a lot of guys come in and say, okay, I'm several years out from my treatment. They were on ADT with testosterone suppression, but their testosterone is still low. What is the safety and efficacy of giving that patient testosterone, if at all? What would be your recommendations or thoughts on that?
Yeah, it's a challenging question, but I think it's definitely a question that comes up, and it's certainly, I think, treating patients that have a history of prostate cancer with testosterone is more in vogue than it was. It used to be kind of really frowned upon. Yeah, but I think obviously patients that have advanced metastatic prostate cancer probably going to be a bad idea. But in terms of someone like you mentioned who has been stable, maybe low grade, not high risk disease, has had a stable PSA, and you're following them with routine examinations. I think that there's certainly more experience and more physicians are becoming more comfortable adding testosterone replacement therapy. You just have to be cautious, pick the right patient, and monitor them carefully, and make sure they understand. There could be some risks, although a lot of the retrospective data that's looked at lower risk patients that have been stable, there hasn't been an increased risk of relapse biochemical recurrence.
Yeah, and I would agree with that. And again, the theme of shared decision making. You talk the pros and cons of it, and my typical recommendation is wait a certain length of time. Is obviously not something that we want to jump into. When they're kind of in that short term remission category. I tend to explore that opportunity a little bit later once we've had multiple PSAs to really document that this is in a deep biochemical remission. But all really good thoughts, and a lot of guys are really enthusiastic to hear that we're open to having that discussion. So thank you. I want to thank all of our panelists. That does wrap up the topics we wanted to cover. I want to go into the question and answer section and believe I want to thank Dr. Carter and Dr. Britt for kind of typing responses as they come up. I think they've all been addressed with nice responses there. So I appreciate all those questions. Along the same lines, maybe this is best for you, Dr. Murphy. You've already touched on it. A lot of our primary care physicians get contacted with some of the side effects of treatment. Before they contact their oncologist, patients, 5+ years out, what would be your recommendations? As you said, we're all willing and able to see these patients, even long term. But what would be the things that you would want to be aware of from our primary care colleagues at, maybe 5 years and beyond if they were having complications related to treatment?
Yeah, well, so I'd probably differentiate if there's concern that the cancer's back. I mean, that's the no-brainer. Get them back to us, and hopefully that won't be the case. But if there's ever any concern of a relapse or recurrence or a metastatic primary, then we're obviously happy to see our patients back. We get great, very long-term relationships with these patients, as you can imagine. From a managing side effects long-term, I think it's almost as a individualized basis. If it's a specialty issue, for instance, the bowel incontinence issue after a rectal cancer, I'm probably not going to help too much on that. I would immediately just go into my cell phone and call one of my GI docs in town and get that person the appropriate specialized care. So I think it's a little bit individualized about who would help manage those toxicities. I think a lot of the toxicities, at least from the medical oncology side, really are just the increased risk that our patients will then confer upon themselves in terms of hypertension, diabetes, obesity, depression, anxiety. These are all at a higher rate of cancer survivors that are really, the primary care doc probably can manage better than I can. But for a specific, I've got a hernia, ventral hernia, I'd get them to my surgical oncologist. Those kind of things, we're always happy to redirect patients. But a lot of the long-term medical oncology side effects are really, it's really just primary care issues.
Yes, thank you. I wanted to go back to one of the first questions that was posed, which Dr. Carter did answer. essentially, what PSA value is our cutoff, and are there any increases that would warrant more of evaluation? One important metric with PSA kinetics is the doubling time. So even though somebody may have a low PSA, if you've been checking PSAs on your patients since the time that we recommend for screening, you kind of get a sense of what that PSA is doing over time. And even if it's in the normal range, in doubles from 2 to 4 or so forth, that should, put up some red flags that something could be going on there. I will also, put a plug in for the digital rectal exam. I know it's not a pleasant exam for our patients and for our providers to give, but it's not uncommon at all that PSA is an unreliable tumor marker for a lot of guys with prostate cancer. So there still is a role for doing a digital rectal exam, feeling for bumps, nodularities, firmness. things that could be subtle, to say, okay, let's look at this PSA a little bit more closely, and so forth. So it's not, not every we see quite a discordance in the PSA production of various prostate cancers. So I just wanted to make that point as well. Look at the doubling time, even though it could be a very low PSA, that matters as well. The other question that came through was, which is a really good question, is how to define quote unquote heavy marijuana use. We find obviously with the way the legal system is handling marijuana now, probably an increase in use, and Colorado being one of the first states to legalize it, maybe got a head start on that type of use. I'm curious if we're going to see an increase in testicular cancer risk or risk of other cancers with that. But as Dr. Britt said, it's kind of been defined as at least weekly use. It doesn't quantify how much, per session, but there's quite a significant increase in the odds of a testicular cancer based on that. Anything to add to that, Greg?
No, again, it's definitely a trend that I think has been looked at. I think anecdotally, it's not uncommon for me to see a young man with testis cancer in his 20s that's also using marijuana on a weekly basis. But again, we're in Colorado, and that's probably a lot of men. But I will say that in terms of this is an important thing with marijuana use, is that it can increase beta HCG levels. And so for patients with seminoma, although it's thought to be associated with non-seminoma, but if you're surveying somebody and they start to have an elevation in their beta HCG, you may want to ask them about marijuana use, because you can get some false positives.
Yep, another really good point. So we're coming up to the top of the hour. I just wanted to have a few closing remarks. One thing that's really important and that our male patients often struggle with expressing is the psychosocial impact of all these treatments on their mental health. And I wanted to just highlight our excellent social work team here at Rocky Mountain Cancer Center that I often make referrals to for guys that, again, our guys are a little bit different than some of our, the women that we treat that are very forthcoming a lot of times about their mental health and their struggles. The guys are a little bit more reclusive with that. So you can get a sense of which guys are struggling, which guys are not. We have an excellent social worker team that has support groups that are geared specifically for our men. And it's really important that they are open and honest with them and their providers as well. So I want to thank our whole team at Rocky Mountain Cancer Center for putting on this educational event. There's a whole team of liaisons that we have that many of you have met that coordinate, organize, and conduct this. And I want to thank them for another educational event. And again, want to thank all of our participants, our panelists and experts in GU Oncology, and hope to see you for our next event. Thank you.